Hello again, this is Christine, and we're going to talk a little bit more about fluid and electrolytes. So starting with checked off sign, and it's a sign of hypocalcemia. You can elicit this by tapping on the face at the point just anterior to your ear, just below the zygomatic bone. And if you have a twitching of the facial muscles, it suggests neuromuscular excitability caused by hypocalcemia. And we're going to watch a video on how to elicit that. And then you have Trousseau sign, which if you inflate a blood pressure cuff right above systolic blood pressure for several minutes, and you find that you get muscular contraction, including flexion of the wrist and the metacarpal phalangeal joints, hyperextension of the fingers, and flexion of the thumb, this suggests neuromuscular excitability caused by hypocalcemia. And I'm going to play a video of it for you here. Okay. So when you're assessing your patient with a fluid disturbance, you start with these parameters. If you're looking at weight and a fluid volume deficit, you're going to obviously have a weight loss, a weight gain, and fluid volume excess. Heart rate, you're going to have a rapid, weak, and thready pulse in a deficit, a rapid bounding pulse in excess, normal respirations in deficit, moist breath sounds and dyspnea with excess. Let me switch to my pointer here. You're going to have a normal to decreased blood pressure in deficit and an increased blood pressure in excess. Skin and mucous membranes will be pale, cool, with poor turgor, prolonged capillary refill, and dry mucous membranes in deficit. You're going to have edema and fluid volume excess. In salivation or tearing will be decreased or absent in deficit. You will have thirst, irritability, lethargy, stupor or coma. That's part of sensorium changes. So salivation or tearing is decreased or absent in fluid volume deficit, and normal in excess. And then in sensorium changes, you're going to have thirst, irritability, lethargy, stupor or coma if associated with metabolic acidosis, and fatigue if it's excess. And so why is that? With fluid volume excess, you're going to start having a backup of fluid in the lungs. That's where you get the moist breath sounds and dyspnea. And then the increased cardiac output is responsible for the rapid bounding pulse and the edema. Fatigue is caused by hypoxia and the increased work on the stressor on the heart. And then the blood pressure is obviously a reflection of the increased cardiac output. Here's some common tests for laboratory diagnostics tests for fluid and electrolyte imbalance. And these are urine tests here. You have urine sodium test is 50 to 130. Specific gravity 1.002 to 1.030. Alright, let's talk a little bit about pH. Here we have the pH scale. This is increasing acidity down to increasing alkalinity. At 0, you have battery acid, lemon juice, vinegar. This is rain here at 5 to 6, milk at 6, baking soda and seawater at 8, milk of magnesia is at 10, ammonia is at 11, lye is at 14. Our body wants to hang out a very narrow pH range, 7.35 to 7.45. It doesn't appreciate getting taken out of that range. Okay. pH is quantified. Let's see. So, and for our purposes, we're going to talk about alkalotic and acidotic. When we're talking about the power of hydrogen or pH, remember it's a scale of 1 to 14. Increasing hydrogen decreases pH. So it seems counterintuitive, and I always get confused with this. Increasing hydrogen decreases pH and makes the blood more acidotic. Decreasing hydrogen increases pH and makes it more alkalotic. We measure pH with an arterial blood gas, commonly known in the clinical setting as the ABG. So what is acidosis? Acidosis is a condition in which there's too much acid in the body fluids. It's the exact opposite of alkalosis, a condition in which there's too much base in the body fluids. Remember, acidosis is from increasing the hydrogen and decreasing the pH. Okay. So we're increasing hydrogen and that decreases pH. The kidneys and the lungs maintain the balance of chemicals called acids and bases in the body. Acidosis occurs when acid builds up or when bicarbonate is lost. Acidosis is classified as either respiratory acidosis or metabolic acidosis. Respiratory acidosis develops when there is too much carbon dioxide in the blood. This type of acidosis is usually caused when the body is unable to remove enough carbon dioxide through breathing. Okay. And I'm going to back up here to acidosis and just let you know that there are some main types of conditions that cause acidosis. But acidosis causes alterations in cardiac contractions and decreases cardiac output. It's also associated with a decreased vascular response to catecholamines, so you don't respond naturally to a fight or flight reaction as you're supposed to. Acidosis also decreases the response to certain medications, and it can lead to a loss of consciousness. Respiratory acidosis develops when there's too much carbon dioxide in the body. This type of acidosis is usually caused when the body is unable to remove enough carbon dioxide through breathing. So respiratory acidosis is caused by carbon dioxide. That's the only cause. Okay. Metabolic acidosis develops when there's too much acid produced or the kidneys cannot remove enough. There's several different types. So whereas respiratory acidosis, there's only one cause, and that's respiratory, and it's carbon dioxide. In metabolic acidosis, there's several types of causes. You can have diabetic acidosis, which develops when substances called ketones build up during uncontrolled diabetes. You can have hyperkalemic acidosis, which is caused by the loss of too much sodium bicarb from the body. When that happens sometimes in severe diarrhea. You have lactic acid buildup in shock. You also have hydrochloric acid. Too much acid in your stomach can cause acidosis. Remember, acidotic conditions cause an alteration in the cardiac contractions, which decrease cardiac output. So acidotic is going to decrease cardiac output. It's going to cause a decreased vascular response to catecholamines, which decrease your body's fight or flight response. And it causes a decreased response to certain medications. It can lead to a loss of consciousness, decreased excitability of the smooth muscle. Okay. In contrast, alkalosis, what happens here, remember, is in alkalosis you have decreasing hydrogen increases pH. So let's back up. Decreasing hydrogen increases pH. And alkalosis is a condition in which the body fluids have too much or excess alkali. This is the exact opposite of acidosis. The kidneys and the lungs maintain the proper balance of chemical to cause acids and bases. Decreased carbon dioxide or increased bicarbonate make the body too alkaline, a condition called alkalosis. Okay, respiratory alkalosis is caused by low carbon dioxide levels in the blood. So in acidosis, it's too much carbon dioxide for respiratory. In respiratory alkalosis, it's too little. Metabolic alkalosis is caused by too much bicarbonate in the blood. Whereas metabolic acidosis, there's many causes. For metabolic alkalosis, it's just too much bicarb. Hypocalemic alkalosis is caused by an extreme lack or loss of chloride, which can occur with prolonged vomiting. Hypokalemic alkalosis is caused by the kidney's response to an extreme lack or loss of potassium, which can occur when people take certain diuretic medications. Compensated alkalosis occurs when the body returns the acid-base balance to normal in cases of alkalosis, but the bicarb and carbon dioxide levels remain abnormal. So, let's talk about this a little more. Alkalosis, increasing pH causes the increase in excitability of smooth muscle. Increases in blood pH interfere with how well tissues oxygenate. And there are some buffers here that we're going to talk about: hemoglobin, phosphate, bicarbonate, and pancreatic fluids. Okay. Unfortunately, the only one of these buffers that's easily utilized is bicarbonate. Hemoglobin you can't easily ramp up production of. Phosphate is not easily used, and neither is pancreatic fluids. So when we're talking about buffers, we're usually talking about bicarbonate. In metabolic acidosis or alkalosis, it's caused by an imbalance in the excretion of acids or bases in the kidneys. So metabolic is going to be kidneys. Many things can cause metabolic issues. The kidneys are just the organ that compensate. In respiratory alkalosis or acidosis, it's caused by an imbalance in the lungs or breathing disorders. So respiratory alkalosis and acidosis, Respiratory is both the cause and the fix. Whereas in metabolic acidosis and alkalosis, many things can cause it, but kidneys are the organs that's compensating. Here's just a review. Metabolic acidosis, pH goes down. Bicarb goes down. Well, we'll go back to this slide after we've talked about it a little more. So, our normal pH is 7.35 to 7.45. And you have PaCO2, which is the amount of CO2 dissolved in the arterial blood at any given time. So this is arterial CO2, and the normal range is 35 to 45. So you can probably remember that if you remember the normal pH. 7.35 to 7.45. Just take those last numbers and remember the CO2 range is 35 to 45. Bicarbonate, which is HCO3, is the calculated value of bicarbonate in the blood, and it's 22 to 26 milliliters MEQ per liter. So we're going to figure out how to analyze the ABG. And the first step in doing so is to look at the pH. Is it acidotic, alkalotic, or normal? Then you look at the PaCO2. Is it acidotic, alkalotic, or normal? Thirdly, you look at the bicarbonate. Is it acidotic, alkalotic, or normal? If both of the CO2 and the HCO3 are abnormal, the one which deviates the most from the norm is most likely causing an abnormal pH. Let's check the PO2. Is the patient hypoxic? So, looking at this slide here, we have a pH less than 7.35, your patient's acidotic. If it's greater than 7.45, it's alkalotic. This should be a review. Remember, carbon dioxide is the respiratory component of your ABG. It's the opposite of the pH. It opposes the pH. PCO2 less than 35 indicates alkalotic. So here, the pH is low. You get acidosis. But CO2, if it's low, it's alkalosis. So it's the exact opposite. Bicarb tells us what the kidneys are doing. It's equal to pH. It goes the same way as pH. So if bicarb is low, you're acidotic. Just like in pH is low, you're acidotic. Bicarbonate less than 22 is acidotic. Bicarbonate greater than 26 is alkalotic. If you're lacking bicarbonate, then we are not balancing acid and it becomes acidotic. So let's look at this little mnemonic. Remember Rome. Respiratory is opposite, so that's the CO2. Metabolic is equal to pH. That's the HCO3. Respiratory opposite, metabolic equal. Alright. PO2 is equal to the oxygen that's dissolved in the blood. Normal is 80 to 100 on room air. That's what RA stands for. Prefer an oxygen of 90 to 100, but less than 80% is hypoxemia. So let's take a look at these pHs. You have pH of 7.36. Is that normal or abnormal? Alkalotic or acidotic? It's normal. I mean, I know I have because your range is 7.35 to 7.45. It's borderline, but it's normal. We have 7.32 is acidotic. Remember, low is acidosis for pH. 7.49, alkalotic. High alkalosis for pH. .55 is really alkalotic, and 7.44 normal. Let's look at the PaCO2s. Remember, Rome opposite. So we have respiratory, it's going to be the opposite, metabolic equal. So we have here, let's back up, take a look at our values again. 35 to 45. Okay, and here, when it's low, it's alkalotic. When it's high, it's acidotic. Okay, so we have a PaCO2 that's 36, that's normal. We have a PaCO2 47, that's acidotic, so above 45. We have a PaCO2 of 70, it's acidotic again, really acidotic. A PaCO2 of 19 is alkalotic, and a PaCO2 of 37 is normal. Okay. Bicarbonate, you have HCO3. Okay, so let's back up here. We want to have it between 22 and 26, and remember, bicarb follows pH. If it's low, it's acidotic. 22 to 26. It's a very narrow range. 25 is normal. Bicarb 35, alkalotic. Okay. Low is acidotic. Follows pH. Bicarb 22 is normal or borderline okay, and then bicarb 26 is normal or borderline high. Okay. We're going to go back to this in a minute. Respiratory acidosis. Remember, it's caused from the obstruction of gas exchange or hypoventilation. Remember your causes of hypoxia. And if you go back, let's go back and look at the causes for respiratory acidosis. Okay. That was quite a few slides back. It's always too much carbon dioxide. And that was quite a few slides. Sorry about that. Alright. Remember, respiratory is going to be PaCO2. It's always CO2. Acidosis is always about the pH. So, respiratory acidosis. So, just looking at the name, you know it's going to be about your CO2. In acidosis, the pH is going to be low. Both have to be acidotic. It's going to be a primary pulmonary problem. And ventilation perfusion mismatch could cause it from unoxygenated alveoli filled with pus or infection, either from infection or drowning, CHF, pneumonia. You could have a hypoventilation syndrome from sleep apnea, cerebral hypoxia, drug overdose, MS, brain tumor, increased intracranial pressure, a Guillain-Barré syndrome, You could have impaired diffusion from thickening of the alveoli membrane, caused by TB, RSV, rheumatoid arthritis, lupus, amiodarone, chemo, antibiotics, COPD. Okay, these are all causes of respiratory acidosis. It has to be a pulmonary problem. Both the pH and the CO2 are going to be low. Primary symptoms are neurologic because as the body develops acidosis, the high CO2 levels cause vasodilation in your brain. And this causes additional symptoms like dyspnea, respiratory distress, shallow respirations, which lead to headache, restlessness, confusion, and ultimately tachycardia and dysrhythmias. Here we have a slide showing respiratory acidosis. Okay, respiratory alkalosis. Okay, so we know it's going to be about the CO2. But alkalosis is telling us that the pH is going to be greater. So we have a PaCO2 that's going to be less than 35, but a pH that's going to be greater than 7.45. And remember, respiratory opposite. I hope I didn't tell you the wrong thing here. Okay. And that's caused by hyperventilation. From pain, anxiety, fear, fever. Fever is a big cause in pediatric patients. It leads to the elimination of CO2, and you get clinical signs of headache, again restlessness, coma, lethargy, dysrhythmias, nausea, and vomiting. So if it's respiratory, it's all about the CO2. Alkalosis, the pH is greater than 7.45. Okay. Here's a slide showing signs of respiratory alkalosis. Okay. This numbness and tingling in the extremities is usually caused from hypocalcemia. And the seizures. Okay, let's talk about metabolic acidosis. Here, we know it's metabolic. It can have a number of causes. Acidosis is going to tell us what about the pH, though? That it's going to be less than 7.35. And our bicarb, even though we know it's going to have a number of causes, the kidneys are the organ that's going to try to compensate. Remember that. And respiratory opposite, metabolic equal. So if pH is low in acidosis, bicarb is also going to be low. There's not enough base in the blood, or there's too much acid. And that could be caused from shock, diabetic ketoacidosis, diuretics, diarrhea, renal failure, and you get headache, lethargy, close respirations, nausea, anorexia, coma, and death. And I'm going to try to switch. Hopefully I'll have better luck. And watch Kussmaul's first. Okay, that's very upsetting. This is a boy in DKA with having Kussmaul's respirations. So you have compensatory hyperventilation, frequent ventilation, and And these are the causes. You have the warm flushed skin from vasodilation, muscle twitching, hyperkalemic, decreased blood pressure. So what's happening in metabolic acidosis? You have a decreased ability of the kidney to excrete acid or conserve the base. If we know that the kidneys are not able to compensate, what's going to compensate? Your respiratory system. That's why you're going to end up having a high respiratory rate. Let's talk about metabolic acidosis, alkalosis. So it's metabolic, we know it's the kidneys, and we know it's all about the bicarb. And alkalosis, respiratory, opposite, metabolic, equal. So the pH is high, so is the bicarb. You have excess base or decreased acid in the blood. It can be caused from overuse of antacids, too much gastric suctioning, vomiting. You get the manifestations of lethargy, dizziness, coma, weakness, muscle spasms, and tetany. Remember, in metabolic alkalosis, the kidneys are not able to compensate. So what's going to compensate? Your lungs. So you're going to have hypoventilation. This is just a chart showing the various mechanisms for acid-base balance. This is okay. So let's talk about a little more about buffers. You have 3 different types. You have chemicals, which act immediately, and there can be bicarb, sodium, phosphate, potassium, hydrogen ion exchange, bones and proteins. You have respiratory buffers, which is carbon dioxide, and that can act in seconds to minutes. So let's say your patient has metabolic acidosis, your respiratory symptom will compensate by blowing off CO2 in a matter of minutes. And then you have renal buffers, like bicarbonate, which take hours to days because the kidneys have to recognize the problem and then change their own metabolism. So you have 3 types: chemicals, respiratory, and renal. When we're talking about chemicals, you have a variety to choose from. Respiratory, it's all about the CO2, and renal, it's all about the bicarb. Let's take a look at respiratory buffering. Here you have your circulation's got CO2 and H2O, and the erythrocyte is this carbonic anhydrase is excreted in response. It travels to the respiratory center in the brain, and it gives off a signal to increase CO2 production, and your respiratory rate increases. If there's a decrease in pH, it can also increase the rate of pH secretion. And that's okay. In renal buffering, to maintain blood pH, kidneys maintain or excrete bicarbonate to compensate. When the pH decreases, the kidneys hold bicarb. When pH increases, kidneys release bicarb. So remember, renal buffering is going to be for a patient with a respiratory problem, because if it was a metabolic problem, the kidneys wouldn't be able to fix it. It has to be the opposite. So example, a patient with COPD chronically holds on to CO2. This leads to respiratory acidosis. The lungs can't fix it. They're broken. Therefore, the kidneys have to try and fix the problem with renal buffering that takes hours to days. They will either hold or eliminate bicarb depending on the imbalance. So respiratory buffering, there's an imbalance in the kidneys. The respiratory system takes over and tries to fix it by increasing the respiratory rate. Renal buffering, there's a problem in the lungs, and the kidneys try to fix it, take over and fix it. You have different chemoreceptors in your body which tell you when you have a lack of oxygen in your medulla, in hypothalamus. You have peripheral chemoreceptors in your aorta, in your muscles, in your lungs, and all of the work in correlation to detect if you have low CO2 or high CO2 or low oxygen, and respond accordingly by increasing or decreasing your respiratory drive. You also have transcellular shifts in acidosis and alkalosis. So in acidosis, potassium gets pulled out and magnesium gets pulled out. So you end up with hyperkalemia and usually hypermagnesium too. So acidosis, hyperkalemia. Remember, hyperkalemia is potassium greater than 5. Alkalosis, you end up with hypokalemia. Remember, you can remember this by taking a look here. LK, low kalemia. Okay? So alkalosis, potassium gets pulled into the cell. Acidosis, potassium gets pulled out. Another component of your ABG is the anion gap. It helps determine the source of the acidosis. The anion gap difference is the difference between the positive cations and the negative cations. And this portion here is your anion gap. Okay, so this is an ABG. Okay, we know our pH should be between 7.35 and 7.45. So acidosis is always going to have a low pH. Alkalosis is going to have a high pH. Rome opposite. So respiratory opposite, metabolic equal. This is just a restatement of what we already talked about. A nice chart, easy to remember. I'm going to just review this though. This is the treatment. So for respiratory acidosis, we know it's caused by CO2. We know the CO2 is high and the pH is low. You're going to correct the ventilation problem. Use oxygen, intubation, and mechanical ventilation, and bicarbonate. Respiratory alkalosis, we know it's a respiratory issue. We know the pH is high, and we're going to end up mild to moderate respiratory alkalosis doesn't usually require specific treatment, but for hyperventilation-induced conditions, you give oxygen, breathing into a paper bag, physiological or psychological reassurance, and institute mechanical ventilation if it's severe. Give sedatives or tranquilizers for anxiety-induced condition. Respiratory opposite, metabolic equal. In metabolic acidosis, you identify and treat the underlying condition, provide bicarb, potassium replacement, mechanical ventilation as indicated. Alkalosis. Treatment depends on the underlying cause. Mild to moderate doesn't usually require treatment. And use of fluids with sodium, potassium, and H2 receptor antagonists to decrease gastric hydrochloric acid is sometimes used. Right. I'm going to talk now about the risk factors for impaired fluid and electrolyte balance. So we have the very young and the very old at risk. Actually, I'm going to stop here and then come back to this in a minute.